cancer types are going to change significantly. So, in my 30 to 39-year-olds, I'm seeing a lot more breast cancer, a lot more colon cancer than I am certainly in my 15 to 19-year-olds. So, when we do fertility preservation at an adult center, we're very familiar with a lot of different oncology types and oncology treatment plans. And, we were really lucky at Northwestern that Teresa Woodruff, who's a reproductive biologist, applied to the NIH and was awarded one of their roadmap grants, which gave her many millions of dollars to create the Oncofertility Consortium. And she actually came up with the term oncofertility. And, prior to this, we sometimes were offering sperm banking here and there, but we weren't always talking about the implications that treatment was going to have on fertility. And once she started the Oncofertility Consortium, once she got this group and kind of moving together, we really saw a lot of momentum around the country. And so initially we had our National Physicians Cooperative, which was this group of mostly academic medical centers around the country, kind of banding together to say, yes, we recognize fertility is a need. Yes, we want to move forward. Yes, we want to make this more accessible for our patients. That's now expanded across the globe. So now we've got centers sort of all over the globe really pushing fertility preservation. And we're certainly not the only ones, right? Almost every single massive organization as it relates to oncology or pediatrics has a statement that's essentially saying the same thing. Sperm banking, egg banking, these are standard options for fertility preservation, and we should be offering them to our patients. So we know that when we're giving certain agents to patients that there is an impact on fertility, and not all agents are going to impact fertility. So I think that's really important to know. Just because your child has had chemotherapy, it doesn't mean that they're infertile, right? There are certain agents that are more high risk for infertility. Those are particularly alkylating chemotherapy agents. Someone who's gotten any pelvic radiation or someone who's maybe had a stem cell transplant, that's more of the high risk. A lot of the endocrine therapies, immunotherapies, those are things that don't necessarily have as high risks. I'm starring some things because you guys, and I've already seen some people nodding like, yeah, my kid had all that. Thank you so much, right? In this particular population, we're using a boatload of alkylators and, we're doing radiation. And so those certainly can have some very lasting impacts on future fertility. Lillian Meacham just published in the Journal of Adolescent and Young Adult Oncology what has been now sort of our guidepost on risk of infertility associated with treatment. And so what we're doing here is we're using something called a cyclophosphamide equivalency dose. So we can look at all the alkylators and we can plug them into this formula that Dan Green out of St. Jude's Children's Hospital came up with to sort of get a rough idea of total dose of alkylators that are used. So when you see that care summary plan that comes through for your child, you can see how much of each chemotherapy was given in total dose, and you can actually plug it into this calculator, and it sort of tells you, does this fall into a minimal risk? Does this fall into a really high level of risk for infertility? We're now using this particular table to also say whether or not someone's appropriate for more experimental options for fertility preservation, like tissue banking. But we all know this, you guys all know this, probably as you're talking amongst yourselves. You're like, well, my kid had this and my kid had this. Our regimens are changing all the time. So that means our risks are changing all the time. We're constantly tweaking protocols based on individual response. So it's not a blanket statement. Not everyone that's in that high level of increased risk is infertile. So again, kind of hearkening back to, it is really important that this is a very personalized and individualized discussion with your providers. I'm going to take all of you back to 7th grade, maybe health class, right? And we're going to talk about how boys make sperm. And just to clarify, and I should have said this off the bat, I'm going to say boys and I'm going to say males, and I'm typically referring to someone who has testicles, right? And I'm going to say women and girls, and I'm typically referring to someone who has ovaries. So I'm not always using general neutral terms, and I apologize in advance for that, okay? But when we think about how sperm is made, right? The pituitary gland is releasing luteinizing hormone and follicle stimulating hormone, and it's creating this entire cascade where testosterone is made, and then the spermatogonia cells, those are the cells that make sperm, get stimulated to make sperm. If something in this pathway gets mucked with, then sperm production can be mucked with as well. And so we know that specifically those spermatogonia cells can be impacted by chemotherapy, and in particular, again, alkylating chemotherapy. We don't often see that the Leydig cells, so those are the cells that make testosterone, we don't often see that chemotherapy has impacted those cells necessarily. When we start to get into radiation, though, it's like a no-brainer, right? If we're radiating the testes, that's going to have a big impact on both those Leydig cells and those spermatogonia cells. Something we don't always think about is if we're doing high radiation to the brain, we could impact the way that that pituitary gland sends those signals. And once we've really messed with that signal, we don't have a great way to replace that yet in men. So if we have someone who's got low testosterone, for example, and they go to a clinic and they're getting testosterone replacement, that exogenous testosterone is actually further impairing sperm production. So if your child has low testosterone, have them see a reproductive urologist and not just some general person who maybe doesn't understand how exogenous testosterone is really impacting the ability to make sperm. When we think about fertility preservation options for males, the sort of gold standard, the most commonly utilized option for postpubertal patients is sperm banking, right? So they get to talk to me, a total stranger, which is super awkward, about whether or not they're masturbating at home. They get to talk to me about coming to a collection room, masturbating in that collection room into a cup, and handing that off to our lab. We're going to analyze the sperm. We're going to tell them more than they've ever wanted to know about their sperm, so their counts, the motility or how the sperm are moving, and the morphology or how it's shaped. Based on that one sample, then we're going to try and freeze into as many vials as we can. With, for my young adult patients, I want to get them 6 to 10 vials stored so that they've got that as a backup. If I have someone who can't yet masturbate but is still postpubertal, then sometimes we can actually go with a surgical procedure called a testicular sperm extraction and go directly into the testicle and get sperm from the testicle that way. If I have a prepubertal young man who is not even making sperm yet, there is a new option called testicular tissue banking. And so there's a handful of centers around the country who are offering this. Most centers are sending that tissue to one researcher in Pittsburgh named Kyle Orwig. And Kyle Orwig is really doing some amazing things with prepubertal testicular tissue. So what he's doing right now is it's a wedge resection of the testicle that's taken, typically pre-chemo. That gets frozen, it gets sent to Kyle, and then the goal is that in the future we can take that tissue and take even maybe the stem cells from that tissue and repopulate the testicle with those spermatogonia stem cells in the future. And he's actually had really good success, and there is a little monkey running around, I think the monkey's name is Gracie, out in Oregon, that was born utilizing this technology. So he's had success in the non-human primate model. He has just opened up studies to be able to do this and offer this in humans as well. So we've been offering testicular tissue banking for probably about the last 10 or 12 years or so. So we do have some patients who are kind of at that point where they're ready to see if this works for them. So my hope is that in the next 5, 10 years, we've got some really decent outcomes data that, we'll be able to share as well. I'm saying this to you guys have all sort of already been through a lot of this, but I think it's important if you are chatting with another family, right, and they've just been diagnosed and they're just learning all these things, maybe one of these options is something that's available to them and to their child. But for most of us, right, like I'm a survivor, right? My child's a survivor. So what do we do now? Where do we go now? And this is a really like a when you're ready now. So I put pictures up there. These are my people at Northwestern that I love beyond nothing else. So Josh Halpern, Bob Brannigan, they're both reproductive urologists. So they've been trained as urologists, but then they went on to additional fellowship to really train in male reproductive health and infertility. And essentially, when I have a survivor who calls me, we talk about, what's been their treatment plan. I actually calculate those cyclophosphamide equivalency doses so that I can share them with my providers to kind of line out high risk, moderate risk, low risk. Then they'll be seen by one of these providers. Oftentimes a history and physical is done. Sometimes now we're doing it via telehealth, thank you COVID. We're going through all their medications. We're doing blood work specifically to look at follicle stimulating hormone. We're looking at testosterone. Sometimes your survivorship clinics, if you're at that point, will already be drawing these levels at some point on your kids. And so you have sort of this serial testosterone level that's been repeated for you. And then we're going to do a semen analysis, right? Which is so not comfortable. Again, it's like, please masturbate in a cup, please hand this off to our lab. And then we're going to kind of tell you, do you have sperm or not? One bad semen analysis isn't the end all be all. And that's why it's so important to see reproductive urology. Because after that, they can sort of say, all right, well, here's, if we see no sperm right now, here's maybe a couple of other options we can pursue. Here's maybe a couple of other things we can think about to make sure that if your child, if they're interested in this, has gone through every possible scenario to see whether or not they can have biologically related children. Something they can also talk about, though, which your kids may not be sharing with you, is some sexual dysfunction, right? So if there has been an impact to testosterone production, we know that low T can cause low libido, it can cause erectile dysfunction. It certainly may not be something that your kid's like, hey, Dad, guess what? Like they're maybe not sharing this, but a reproductive urologist can ask the right questions, and if there are some sexual dysfunction issues, can also help address that, again, when your kid's ready. Let's talk females, okay? Because it's a different ballgame. Men are typically making about 1,200 sperm with every heartbeat, right? Not the same for women. We're born with a set amount of eggs, and as we get older, we just keep losing those eggs. For most women in the United States, if they've never had something happen to them, they're going through menopause about the age of 51 or 52, and that's when all of those eggs are pretty much gone. Most of us, though, are done having babies in our early 40s. That's because what eggs are left have been so degraded and the DNA inside of them is just not capable of producing a live birth. So when we, kind of describe female fertility to our female patients, I sort of walk them through a whole menstrual cycle, right? Because I think, number one, a lot of people don't realize that they're born with all the eggs they're ever going to have with no way to make new eggs. They just assume because they see Janet Jackson at 55 having a baby that they'll be able to have a baby at that age too. And newsflash, that's probably not the case, and maybe she used donor eggs or had her own eggs frozen. But so we'll kind of talk about what a menstrual cycle is like, because that also helps then facilitate the discussion about what egg banking looks like. So sort of each month, again, taking you way back to like maybe the 5th grade movie that you guys all had to sit through where you like learned about how babies are made. So each month, right, in a woman, her brain is sending follicle-stimulating hormone to the ovaries, and there's this pool of follicles that's sitting there. It's called the antral follicular pool. And one of those follicles gets selected. It then ovulates out that egg. If that egg's not met with sperm, about 2 weeks later, you have a period. And then that cycle just repeats and repeats and repeats. And that'll be important as we talk about what we do for egg banking. When we think about how our treatments are impacting female fertility, we're really concerned about the number of eggs that are left after treatment. So we know, again, particularly that alkylating agents can really decrease the number of follicles that remain in someone's ovary. When it comes to abdominal radiation, it's like a no-brainer that yes, it's going to impact that number of follicles, but another thing that abdominal radiation can do is really impact the uterine cavity itself. So when we've had women who've been exposed to pelvic radiation, what we see are higher rates of miscarriage, we see higher rates of intrauterine growth restriction, we see the blood vessels maybe not able to feed the placenta like it needs to during a pregnancy. So anytime we've had someone exposed to chemotherapy, radiation therapy, these are all big reasons that we would want them to be seen by reproductive endocrinology, and then when ready to have a baby, potentially even someone like a maternal fetal medicine to like really make sure that this pregnancy would be safe to carry out. This was a study, and it's funny because I presented this to the survivors, and I was like, it's kind of a newer study, and I was like, oh no, it's 2006. Some of these kids weren't even born yet in 2006, but for me, we were excited when this study came out because it was one of the first, and it looked at, young adult patients, but it was one of the first to take these time points of hormones and to see when someone's getting chemotherapy, which is that black line, that thick line down at the bottom, to see what acutely happens to those hormones. So in particular, AMH, or anti-Mullerian hormone, it's a blood test that we can do on women, and that hormone is secreted by all these growing follicles in the ovary. And what you can see here is that AMH starts, around 1, and by that 3rd month of chemotherapy, it's already like completely dropped down. And then you see it takes a long time for it to come back. And for my patients who've been acutely exposed to chemotherapy, I'm typically telling them I don't want to see them for an AMH test until they're at least 1 year out of their last chemotherapy dose. Because if I take it at time point 6 months, post their last chemotherapy, it's still going to probably be very bottomed out and not give us a real number. We definitely do see some increase in it once we get to the 12-month, 18-month, even sometimes that 24-month mark. And this is a graph that I often use when I'm in the room with a patient kind of describing fertility. Again, showing this finite amount of follicles, how those follicles and those eggs inside decrease. And then again, because I'm seeing mostly adults, I'll have like a 20-year-old. And so we'll talk about if it's a patient who's not getting a lot of alkylating chemotherapy, still getting some, but not much. We'll talk about maybe that chemotherapy not having a huge impact on fertility. Yes, it may change the trajectory of when she goes through menopause. Maybe it makes it a year or two earlier, but the timing to which she'd have to get pregnant likely won't be significantly impacted. And I think it's important. I think it's important to still talk about fertility in those cases, but I think it's important to provide patients with the information that we think that they're going to be fine. If I have that same patient, though, and she needs to get some alkylators but doesn't put her in that high risk, what we talk about then is sort of this decreased time to which she'd have to get pregnant. So again, not making her infertile after treatment, but making it so that maybe she goes through menopause at 41 instead of 51. And that's just because she's lost sort of this cohort of eggs. And I certainly have patients that I see who are getting ready for a stem cell transplant, for example, who are going to get total body irradiation, really high dose alkylators. And in those cases, that treatment's going to put them into menopause directly. And so those are our very high-risk cases that we want to make sure that we can discuss fertility preservation so that patients have options if available. I also sort of gray this out because I can line up 2,100-year-olds and I can measure all of their ovarian reserves, and it's a bell curve. So obviously I'm going to have a lot that are right in sort of the normal range, but I'm going to have some who already have subfertility, who already, for a variety of other reasons, have lower fertility than we would have expected them to based on their age. And so when we think about fertility preservation options that we offer to our patients, egg and embryo freezing is probably what's most often done for our adolescent and young adult patients. The youngest patient that we have frozen eggs on was 10 and a half. And it's a lot to go through. It's a 2-week process. We'll get a little bit more into that. And it's not something that's for everyone. In some cases, when someone's getting pelvic radiation, we can do what's called an oophoropexy. So I just like to say that word. It's kind of fun. It kind of rolls off your tongue. But it's essentially where we take the ovaries and we tack them up outside of the pelvic radiation window so that we can kind of protect those ovaries. And then, potentially those ovaries still are going to produce some hormones too for that patient. We do this a lot in a lot of our gynecological malignancy patients where we're going to do some pretty hefty pelvic radiation. We can move those ovaries up and out and then potentially save them a little bit from that radiation. Ovarian shielding is something where they can put sort of a lead shield just where the ovaries are and maybe help protect a little bit from some of that pelvic radiation. When I actually did grand rounds for my radiation oncologist, they were like, no one does this. So I keep it on there because everyone talks about it, but they said in practicality, if you need pelvic radiation, you probably shouldn't be shielding anything in there. So it may be an option, but I think it's something to ask about. We also, and I don't know if any of you guys experienced this, if your kids were old enough at the time, but in some cases we'll put patients on a medication called Lupron. It's a gonadotropin-releasing hormone agonist, and essentially what Lupron does is it just shuts the ovaries down. It's putting someone into a medical menopause. The theory being that if the ovaries are so quiescent and quiet, then maybe the chemotherapy won't do as much damage. And I say maybe because the data are very, very mixed on whether or not it actually works. So it's something that gets offered, but something that's offered with sort of this, we're unsure of how well that works. And then we're going to talk a lot about ovarian tissue freezing and kind of where the science is at with that. So egg freezing. Egg freezing from start to finish takes us about 2 weeks to do. We are using stimulation medications. So remember back to that slide about follicle stimulating hormone growing that one follicle. When we're using stimulation medications, it's just extra FSH so that we're telling instead of that one follicle to grow, that whole pool of follicles to grow. We sort of block ovulation midway through that cycle, and then we give a trigger to get those eggs inside the follicle ready for retrieval. And that's what you're seeing here. So this is what a retrieval looks like. It involves a transvaginal ultrasound, and using that transvaginal ultrasound, we can visualize the ovaries on the other side of the vaginal wall, and that's what you see in that sort of little picture that's in there. You can see that sort of black and white picture. That's an actual ultrasound of an ovary. And you can see this very white line going into a follicle. The follicles look like these black balloons. So when someone's under conscious sedation, so they do not feel anything, they do not remember anything, we use a needle, we go inside each follicle, we turn on suction, and we aspirate each follicle, pulling out the follicular fluid and the egg inside. Then we know that same day how many eggs we got. Those eggs get frozen. If someone has a sperm charming that they want to use, then we can fertilize those eggs, make an embryo, and those embryos are typically grown out to day 5 or 6, and then they're frozen at that stage. And something we talked about in the survivorship group was, at that day 5 or 6 stage, they can also do genetic testing. So you can get a lot of information back about these embryos if you want. So if there's a known genetic mutation, so if someone is a carrier of a BRCA mutation, a genetics company can create an assay and actually run each embryo against that assay, and then they give you a report back about embryos 1 and 2 are affected with this mutation, embryos 2 and 4 are not. They can also give you information about the number of chromosomes present in each embryo. And again, it just gives you kind of more information about which embryos you want to put back, which ones you don't, and what's going to make the most sense for you and your family. Egg freezing is a lot, right? So it's 2 weeks to do. Not everyone has that time before treatment starts. A patient has to be post-pubertal to be able to undergo this. We cannot make an ovary grow eggs without someone have already gone through puberty for the most part. It does involve transvaginal ultrasounds, which even as an adult are not that comfortable. So for young kids, it can be quite a bit to do that. Sometimes we can do transabdominal where we're looking through the abdominal wall, but it doesn't always provide the same results. And, the patient needs to be healthy enough to wait those 2 weeks and then to be able to undergo an egg retrieval, which just isn't always the case. One sort of caveat with this, and something that I run up against all the time, is people are like, oh, well, we have to wait for someone's period to start to be able to do this, right? The answer to that's no. We can actually start a stimulation cycle at any point in a menstrual cycle when we're doing it for these purposes. It's not a 100% guarantee if we've frozen eggs or embryos that that's going to result in a pregnancy either. So I think that's important to consider. You can see success rates. This is from our Society of Assisted Reproductive Technology. We sort of all pool our data together into this website, and it spits back, what are pregnancy success rates. But you can see those success rates, and this is with frozen embryos. Even in patients who are under the age of 35, only about 55% of the time are getting pregnant, and you can see, that significantly drops as the age of the egg gets older. So if we've got, an egg from someone who's over the age of 42, there's only about a 4.5% chance that they're going to get pregnant with that frozen embryo. Eggs are a little bit different. Egg freezing is a little bit newer of a technology. It was experimental until 2012. So I utilize this kind of graph when I'm talking to patients about success rates and kind of thinking about how many eggs do we want to shoot for. And I find this especially helpful in my survivors, right? So if I have patients who've already been exposed to chemotherapy, they know they have diminished ovarian reserve or not as many follicles left, but they want to freeze eggs after treatment once they're in their late teens, early 20s, then we kind of use this graph to help guide us about how many eggs do we want to try and get for you, right? And maybe that means more than one cycle. And so you can see here, if I've got 10 eggs in a 32-year-old, that's going to give her a chance of success for a pregnancy of about 50 to 60%. But if that patient's 41 and I get 10 eggs, that chance of having one live birth is about 20%. So that egg age makes a huge difference. Let's talk tissue freezing. So we have been freezing ovarian tissue in patients for about the past 14, 15 years or so. Essentially what happens is before treatment, we remove an entire ovary, we isolate the outer edge of that ovary, and we slice it into these cortical strips, which is what you see up here. These cortical strips are then frozen, and they kind of stay frozen until you're ready to use them. Historically, we've been doing transplantation with these strips. So we actually thaw the strips and we sew them back together in what looks like a quilt, And then we put that quilt back on the remaining ovary. The ovary recognizes its own tissue, starts to wake up, it gets the signal from the brain, and it starts to grow eggs on its own. And, the reports are a little bit mixed, but there are at least 130 live births from this transplantation technology worldwide. For some patients, though, we can't transplant that tissue, right? So I have patients who have leukemia, for example, and there's a chance that by taking that tissue out and then putting it back in them, we could reseed them with their cancer. So in certain patients, doing a transplant like this is contraindicated. So what we're working on, and a lot of different groups around the world are working on, is something called in vitro follicle maturation. So what we initially started with was encapsulating a follicle that we pulled out of ovarian tissue into a gel system. And then we send hormones through that gel system to coax that follicle and to coax that egg inside the follicle to grow. And we've had some success with getting mature eggs from that technology. It's super inefficient. So we had 44 patients that donated tissue for this. 65 follicles were isolated from that tissue, and we only got 4 mature eggs from that. But it was a start, right? And we all kind of have to start somewhere. So this was published in 2015. There's now been another group that worked on this in 2017. Another group just published it on 2021. So the hope is that, for my patients who right now are doing tissue freezing and need this technology in the next 15, 20 years, we've hopefully got this figured out. We're also looking at it in a new way. So we've been looking at 3D printers to help us create an artificial ovary. So what we've worked with initially was bovine ovaries, so ovaries from cows, because they're actually somewhat very similar to human ovaries. We've decellularized these bovine ovaries, and then we crushed that and made a powder. We then turned that powder into an ink, and we've been 3D printing a scaffold so that we can create this ovary almost that we could then put follicles into so that we could coax lots of them to grow. So I think our hope here is that maybe we could even find ways to help with, getting someone through puberty with their own ovarian tissue. Maybe help with a little bit of hormone replacement. This is very, very, very new technology. We did start this in 2015, but we're still definitely working on it. I can't even guess how soon this would be ready, but I just want you to know that there's just this crazy constant science going on, really all around the world. And that just because we made an ovary paper. So that's just showing you that we could crumple it up, and it was a very pliable paper that we made out of this ovarian ink. For a lot of you and for a lot of your kids, it's thanks so much for all this information. I'll sure to pass this on, but my kid's already gone through all this treatment. And so what do I do now? Where do I go from here? And, I'm big on reproductive endocrinology. So these are OBGYNs who did a special training and fellowship, particularly in reproductive endocrinology. And so as your child gets ready for this and starts to ask questions about, fertility or family building or things like that, these are really good people to seek out. And what they're going to do is just, like most doctors, a full history and physical. They're going to go through all those medications. Same thing for our REIs is that I send them the cyclophosphamide equivalency dosing. I tell them kind of where we're at risk factor-wise. We'll look at any surgeries that happened in the pelvic region. And then we're going to start with labs. So labs are something that can be drawn in survivorship clinic as well. At Lurie, at the survivorship clinic I work with, they actually get these labs for me so that patients have this information coming into us, but we're going to look at ovarian reserve, primarily do this through anti-Müllerian hormone. If someone's cycling and not on birth control pills, we can look at estrogen, follicle-stimulating hormone, luteinizing hormone. They can basically pull a whole full hormone panel, and that starts to give us an idea of current ovarian reserve or kind of how many numbers of follicles are in there. We can also do a pelvic ultrasound. Again, not for everyone, but sometimes we can see the ovaries abdominally to kind of get an idea of how many follicles we see. And if someone is partnered and ready to build their family, we are definitely going to also do a partner evaluation, right? This is not just all about women fertility. Even if someone's been exposed to chemotherapy, I've had plenty of patients come in as survivors with their partner, and they're like, we've been trying and trying, and we don't know why we can't get pregnant. And I'm like, it's because your partner has no sperm. Right? So that's a huge part of this too. This is my go-to team at Northwestern. So Kara Goldman, Mary Ellen, Emily, these are all reproductive endocrinologists. These are like the people who, are going to do that initial intake. But I also then have a lot of patients that come to me who are already in menopause or who we know are going to be in menopause because of the treatments that they had. And I now am referring them out to my Center for Sexual Health and Menopause. So Tracy Kurtzer is a general OBGYN, but this is what she does, is just hormone replacement, making sure that everyone's on the right dose of estrogen that they need to be on to make sure we protect their bone health and their sexual functioning and their cardiovascular health. So I feel really lucky that I've got this team. We're all on the same floor. But I think, for you, if you're at a spot where your kid is ready to start learning about this stuff, or your young adult is ready to start learning about this stuff, I would encourage you to find a reproductive endocrinologist or a reproductive urologist who can sort of start to help you guys walk through what things look like now. And I heard you guys at the previous talk, like, how can we be involved? How can we do more? Like, you guys already, you are here with like these amazing providers who are doing all this work. You guys are boots on the ground making things happen. We, throughout the country have been working really hard to get fertility preservation as a covered law, meaning that if someone's been diagnosed with cancer and they're going to get treatment that's going to impair their fertility, this should be a covered service. This shouldn't be something that people have to pay out of pocket for. It shouldn't be a decision that my patient has to look at their bank account to decide whether or not they can afford to do this. This should be a covered service. And so what you see here in the green are all the states that have passed legislation around medical fertility preservation. States in blue are working on legislation. States that are in that weird beigey yellow color had legislation that then dropped off, and then states that are in white have nothing going on. So if you're in one of those states and you want to get something going, the Alliance for Fertility Preservation, which is listed at the bottom of this, has been going state by state, doing hand-to-hand combat with legislators to get this moving forward. And so when we did it here in Illinois, we went down to Springfield, which is way downstate. We talked with legislators. No one wanted to talk to me. No one wanted to talk to any of the doctors. They wanted to talk to parents, and they wanted to talk to survivors. And we had amazing parents that went down multiple times to educate these legislators about fertility preservation, multiple patients that went down multiple times. So that's how this stuff gets through. It is not from doctors and people like me. So if you're in a state that doesn't have law and you'd like to get involved, you can literally Google Alliance for Fertility Preservation. It'll pull you right into their website. Joyce Reinecke is who runs it. She's their executive director, and she is fabulous. She can help hook you up with the people in the state who are doing what needs to be done. So thank you. I'm the last talk of the day. I kind of joke that everyone should have had a glass of wine for this talk, maybe a couple, me included. But this is my name, this is my email address, this is my phone number. This website now takes you to Michigan State, which is now where Teresa Woodruff is president, but you'll still see my face up there. It's just a Michigan State website. But feel free, please, to reach out, or if you've got questions after this and you want to chat, I'm more than happy to chat.
Thank you. Does anyone have any questions? Okay. Yeah. We'll have.
Hi.
Hi.
My daughter was diagnosed at 4.
Yep.
And after she just had chemotherapy at the age of 4, and then she went in remission, and she started to start to bud like normal kids do, having the she said woman business. That's what she called it.
I love it.
And then she relapsed at 8, and then we had to have chemo and proton radiation, and it's just like it just drew back in all the budding, everything. It just went away, and now they have her on the estrogen patch because she has like no type of cycles or anything. They never talked to me about preserving anything, or the big issues that say, hey, your kid may never have any kids, and she actually said she wanted a farm full of kids.
Yeah.
And so now she's like, she does not want to talk about those things. She kind of shut down when we go to the endocrinologist and stuff like that. So why don't the doctors tell us when we're about to do the chemo and radiation, like, hey, your kid's eggs are going to be fried. Let's see what we could do first to help these kids out, to say, hey, maybe you might want to have kids in the long run, you know, so that would give them a chance, or the parents a chance, to figure out maybe there's something else we can do to prevent this when they get to become teenagers and think about it. They get depressed about those things,
Yes.
not being able to have kids and you know,
Yes.
carry on their legacy. So why isn't this one of the things that's like high on the list to talk about?
Yeah, and I think you're going to find that by institution, it's very different, right? So you're going to have certain institutions where they've got fertility champions, and this is top of mind, and they do discuss it. Sometimes they send me referrals, and I'm like, you guys, enough. Like, I'm good. No, this patient doesn't need to see me. But I think a lot of it is institution specific. I think a lot of it too is that, I mean, you guys all know this. Holy shit when a diagnosis hits, right? And then when a relapse hits. And then you've got all these other things that are going on, and everyone's trying to get you through all these things. And you're becoming an oncology expert in the midst of a complete existential crisis. And maybe it gets mentioned, but like doesn't even filter through. I think what you'll find, and what we've definitely seen with pediatric oncology, is, you know, they are really pushing hard to make this standard, to make it so that in our electronic medical records, a questionnaire stops them from being able to move forward to give chemotherapy, to say, did you talk about fertility yet? I think you'll find that they are really figuring out ways to make this better, because you're right, this sucks when it happens and you don't know about it, and then your kid's dealing with infertility at the age of 16, and then dealing with hormone replacement and having to go through all these things that none of their peers are going through. They've already lost a lot because of this diagnosis, but to have that additional loss of family building the way they envisioned it really sucks. And I think what's happened is that you've seen survivors come back to their oncologist to say, what the heck? Why didn't you talk about it with me? And, you know, I can tell you around the Chicagoland area, I have been amazed at how well the oncologists do approach it and how often they're talking about it. And it's not just the first visit, but it's the second visit, and it's before chemo, and it's in survivorship. And I think as a whole, the group is really working hard to make this better, because it shouldn't happen.
Okay. Any other questions? We got one here. Go ahead.
Jacqueline from Oregon. So like, what are the most common issues that you see in patients who are very young, like underneath a year, who went through chemotherapy for at least a year, and like what to watch for in them as they're getting older for like infertility?
Yeah, so I think, you know, I'm such a huge proponent of survivorship clinics, and I think survivorship clinics do such an awesome job at catching these things that you would want to start to look out for. So, you know, going through puberty is kind of this first piece of things, right? Like, does my child go through puberty on their own, and what does that trajectory look like? And the endocrinologists at pediatric institutions are so brilliant usually at like helping you walk through that. So if someone's gotten through puberty on their own, then I think it starts to get into, what do menstrual cycles look like? And not all menstrual cycles are going to be regular. That doesn't necessarily mean infertility, especially in adolescence. But then it's starting to track those menstrual cycles, you know, starting to, if you're noticing any signs of menopause, and they're going to be the same as they are for us in our 50s. So hot flashes, night sweats, insomnia, mood changes. If they're going to tell you about vaginal dryness, I know, all these things suck. So if those are some of the symptoms that someone is having, then I do think it's probably time to have a conversation about, what does my kid's fertility look like at this point? And then kind of seeking out, if you've got a great OBGYN or maybe a pediatric adolescent and gynecologist who can kind of help do some of that initial testing and then even further refer you to an REI, that would be sort of the path that I would recommend.
Okay, someone else?
Kind of went along with my question. So you talked about this AMH test
Yeah.
and how it should be 1 year post chemo. Is that age specific? Because I too have an infant that went through chemotherapy under
Yeah.
age 1. So is that something that we should be monitoring now? She's only age 2.
Yeah,
Or
it's not
just
going to
wait
help
until
now.
survivorship? Because I know
Yeah, I
we're
would
not
sort
going
of-
to enter survivorship till she's about age 5.
Yeah, I would even wait actually until she starts to get, if she goes through puberty, into puberty. Because it's really like, we don't even have norms for AMH until women are through puberty. And one of the biggest publications has like 17,000 enrollees in it, and it didn't even start till age 24 to give us like age norm AMH levels. There are groups with the Oncofertility Consortium we have, it's called the Pediatric Initiative Network, that have been trying to do some AMH studies specifically in pediatric patients so that we can have some of this information, but we don't have those sort of normalized numbers yet for that population. AMH becomes really more helpful as people get a little bit older, as they get through puberty and then kind of continue. But it's also not the end-all be-all, right? So it is one level. And this is what I tell all my patients, it's one level at one time point, right? And so it is something we'd recommend to be looked at. It also doesn't say whether or not someone can get pregnant. So we know women with exceedingly low AMH levels can still get pregnant. So having a very, very low AMH does not mean infertility necessarily. It just is more of like a, should we think about egg freezing at this point versus later? Yeah.
Okay. All right. We have you, and then we'll go to you second.
All right. My name is Peggy. I'm from New Jersey. You spoke of a calculator earlier. Is that a calculator that we can have access to, or we come through Northwestern for that calculator?
Oh, no, so it's published in the Journal of Adolescent and Young Adult Oncology, which is it's JAYAO, but it's like one of the medical journals that we, a lot of us in adolescent and young adult oncology kind of publish some of our works, but that's sort of where that calculator sits. Honestly, too, within your survivorship clinic, they should be able to do that for you and kind of pull it for you. It initiated out of a paper from St. Jude's from Dan Green, so that's kind of where they actually break down all the calculations and everything like that.
Okay. One back there.
Hopefully this will be a quick one. In the slide with the ovarian tissue cryopreservation, you had mentioned that BRCA2 would be kind of eliminate the patient from qualification for that. If the patient does not have that gene, but their tumor does, would that disqualify them?
Oh, this is one I've never gotten in 13 years. So the tumor itself had the BRCA2 mutation, but the patient doesn't. That would be a little bit more of a complicated case where I would 100% loop in my genetic counselor, who could help then delineate what risk of that. So the reason that we talk about it being contraindicated in someone with a sort of germline BRCA2 mutation is because those people are typically at risk for having ovarian cancers, right? And so we remove the ovaries prophylactically before that happens. And so the thought is, why would we then put that tissue back into them to maybe have that happen? Whew, if it's just in the tumor, I don't know. I don't know. Yep. I'm sad to leave it on a I don't know spot, but
Okay.
thank you guys so much
anyone else?
for all your attention.
Oh, one
Yeah,
more
yep,
question.
I'm sorry.
Yeah, we have one more here, or two more.
The legislation is really exciting, so thank you for that. Is that before or after treatment to get approved for something like that? And also, is there any benefit to doing the egg freezing after puberty? A child has had treatment early on, they hit puberty, doing that versus waiting for them to turn 20 and try to get pregnant naturally. Like, is there benefit to?
Sometimes.
Okay.
Sometimes, which is kind of a shit answer, I know, but it really is so dependent on that person's individual fertility and sort of their family building goals. And so, I even see this like in some of like my med students, right, that are, at Northwestern and they're med students, they know they won't have a family for the next 10 or 15 years, and they're freezing their eggs up front because they know by the time they hit their 40s, their fertility will be subfertile. So, I definitely, when we work hand in hand with survivorship, it is all about very open counseling, right? And very much so, let's check these levels. Let's see where they're at. Let's talk about egg freezing. Is it feasible at this time point? Is it affordable at this time point? Will insurance cover it? These are all big factors into whether or not someone pursues this. And, you know, all that we want for these patients is to be able to make an educated decision about what's best for them at that time. And so I think in some cases where we're seeing AMH levels go down, 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 and we're starting to see someone go into menopause early, if we have that window that we can get some eggs, yeah, let's do it. But again, you know, it's not a guarantee that pregnancy will result from those eggs, but it's kind of the best of what we've got right now.
Okay, one more question then?
With the testicular tissue bank, is it possible to do it after treatment? Are they open to that, or are they? Okay.
Yeah, so Kyle, who, you know, runs most of the protocols across the country, he is pretty lenient on inclusion-exclusion criteria in terms of how much chemotherapy someone has had. He does still have some exclusion criteria that I don't know off the top of my head, but he has definitely enrolled patients in tissue freezing after they've had some cycles of chemotherapy.
Okay, and I assume emailing
Yeah.
him be the best?
He's
Okay.
amazing. Like super on top of it. He's like really, really smart and also very, very normal, and you could have a beer with him, which is a rarity sometimes with some of our like basic scientists. He's fabulous. And his website gives a lot of really good information. He's got great coordinators. Yeah.
We've tried getting him 2 years in a row,
Yes.
so.
He's a busy man.
Yeah, so
Yes.
hopefully next year we can.
Yeah.
Okay, one more question?
When should parents, in terms of age of their child receiving treatment or being diagnosed, should be talking to someone like you?
I think that totally depends on where, you know, the parents are at a trajectory and the kids at too. You know, I think, you know, I have kids, like I had a 10-and-a-half-year-old who came to me and wanted to freeze eggs, and they knew that that's what they wanted to do. And we had a lot of ethics consults, but that's not every 10-and-a-half-year-old, right? I have some patients who are 20 and are like, I absolutely cannot do this right now. So I think it's so individualized, and I rely really heavily on our survivorship team to kind of initiate that conversation with families and sort of gauge interest there, and then based on that interest, you know, they kind of refer out to us.
Obviously, it would be best that they be talking to someone like you before any kind of chemo exposure.
1,000%. That is always our goal, is pre-chemo, we can intervene if,
Is there, again, an age limit for at least some kind of counseling that give the parents some kind of idea what they might be, how to plan or deal with this if as chemo's coming?
yeah, no age limit. So both testicular tissue and ovarian tissue go down to age 0.
Okay.
Yeah.
Then one last question, or please repeat it because I sometimes forget. You had on the map a bunch of facilities. Are they at the same capability as let's just say you are at Northwestern in terms of competence?
I mean, yeah, no. But totally, I mean,
Is this?
yes.
I mean, you know, this
There are some just bang up fertility clinics out there that do really, really, really great work. But there are, you know, we're getting ready actually for our Oncofertility Consortium conference. And so there are definitely REIs who do a lot more cancer than others. You know, there's going to be some private clinics who, like, if you walked in there and you're like, my child had neuroblastoma, you'd see the REI like Googling what's neuroblastoma.
Right, yeah.
So, I mean, there are definitely some clinics, and they're typically going to be found at like large academic medical institutions, often where you see them in conjunction with cancer centers. Those are kind of the places to seek out.
About 15 years ago, my daughter was being exposed to chemo. And I want to thank Dr. Marichellian for setting it up. She was kind of a cutting edge on getting our daughter to see someone like you way before anyone was really even talking about it.
See what I'm
Thank
saying? Pediatric oncology. Yes.
And one last question?
I was having this topic with another neuroblastoma parent in the past, and they made a comment that I've never really forgotten. They said, well, maybe kids with this diagnosis shouldn't be having kids in the future. And I don't remember if the context was like because of the diagnosis or because of the treatment. I don't recall that component of it, but I was wondering if there's some sort of data or how you would react to that.
I mean, did you see my face? I about threw up in my mouth a little bit. My reaction to that is that people are dumb sometimes. I mean, there are lots of different genetic mutations, lots of different things that go on, but I don't think any of that precludes someone from being able to explore biological family building. And I think, what a shitty statement, right? Like, yeah. Yeah, there has been, to actually give some data, but Dan Green, again from St. Jude's, has done some studies on adult survivors of childhood cancer who were exposed to chemotherapy, and they did what's called a sibling study, where they followed both the patient and a sibling, and then they looked at offspring from both, so using the same genetic pool, and they did not see any increased risk of, offspring with genetic mutations or single gene mutations, specifically because someone had been exposed to chemotherapy or radiation therapy. So, I mean, that is pretty good data that's out there, and I think maybe, I'm sorry that you even had to hear that. Yeah.
Okay, anyone? Okay.
I'm sorry I cussed a lot, too. I'm realizing that is, yeah. So classy.
Okay.
Yes.
Thank you, Kristin.
Yeah, thank you,
Thank you,
guys.
everybody. I love your language. It's awesome. This concludes for today. We do have dinner, DJ, dancing, like I said, next door. They're setting everything up, and that'll be at 6:30. So if you feel like being, a part of it, you can go outside too, but it's free food. Come and enjoy it and have a good time. Thank you.